Is your practice tired of wrestling with insurance denials, deciphering EOBs, and watching your revenue slip through the cracks? You are not alone. Welcome to The Claim Game, the podcast designed to cut through the confusion and provide you with the best practices for revenue cycle management success. We are Jeremy and Catherine Zug, and we've been with people just like you in the trenches. Each week, we'll break down complex billing processes, share real-world solutions from practices like yours, and ask questions of the game makers and changers of healthcare so you can take control of your revenue. Let's turn those claim denials into deposits and help you return to focusing on patient care. It's time to win the claim game.
Welcome back to The Claim Game. As a reminder, so often we like to take a pause to get a behind-the-scenes look at the very structure of the system of healthcare and the game that we play often with insurance companies and patients. Think of this as consulting the game makers or the game changers themselves of healthcare. These special episodes offer invaluable insights into the design and development of the healthcare landscape. By interviewing these people, the payers, regulators, and other key players, we can gain a deeper understanding of the rules and nuances of how to navigate a really complex healthcare system. This knowledge will give you a significant advantage, allowing you to navigate the terrain with greater clarity and make more informed strategic decisions. So we're going to learn from a game maker today, and today's game changer is Amy Turner. Amy serves as the Deputy Director for Policy for the CMS Innovation Center, where she manages the center's model test portfolio. She oversees the development, clearance, and implementation of approximately 25 Innovation Center model tests designed to promote fiscally sound healthcare service delivery, transformation, and increase access to high-quality care in Medicare, Medicaid, and CHIP. Amy has spent 30 years of experience in healthcare policy, rulemaking, and insurance oversight. Prior to joining the Innovation Center, she was the Deputy Director for Policy in CMS's Center for Program Integrity, where she was responsible for preventing fraud, waste, and abuse in Medicare, Medicaid, and marketplace plans. She began her career at the Department of Labor, where she led numerous tri-department between the Department of Health and Human Services, Department of Labor, and the Department of Treasury, healthcare regulatory teams, including serving as the Labor Department's ACA implementation lead and then Deputy Assistant Secretary at the Employee Benefits Security Administration. She has a Juris Doctor from George Washington University Law School and a Bachelor of Science in Industrial and Labor Relations from Cornell University. Please welcome Amy Turner to The Claim Game.
Sure.
Talk a little bit about how you got to where you are, because I don't know if it's a lot of people's dream to work at CMMI. So maybe talk about where you got your start, and then what is CMMI and what are models that you're working on, particularly WISeR?
Yeah. Okay. All very good questions. And my guess is you probably have a lot of healthcare policy nerds that call into your podcast. So they may find this kind of interesting like I do. So CMMI is the Innovation Center. It is sort of this wonderful little treasure in the federal government where our statutory mission is to do one of three things. One, figure out how to bring down costs while holding quality constant. Two, figure out how to raise quality while holding cost constant. Or the mother lode, reduce costs while improving quality. And I'm sure a lot of your listeners know the healthcare is just an incredible, it outpaces so many, the inflation for healthcare and for higher education just outpaces so many other items and services in our country. It is an enormous proportion now of our GDP, and we're just not on a sustainable path. So that, coupled with the fact that compared to other OECD countries, Americans don't live as long, we don't live as well. So we're throwing all this money at the problem, but we're not living longer, we're not living better. The Innovation Center was created by the Affordable Care Act to address those problems, to figure out how to get us more value for our money. And I feel like value can kind of be this tricky word. I was once in a meeting where somebody had said, I don't buy value bacon. Why would I want value healthcare? But I think
good.
the way that I look at it is sustainability,
Mm.
and also getting to WISeR, patient safety, because if the system is set up to just reward, like every time somebody does more services, they get paid for it, that is not a sustainable system in terms of our economy, in terms of Americans being able to pay for it, but it's also a dangerous one. Unnecessary services, introducing the risk of anesthesia, introducing the risk of hospital-acquired infections. It doesn't work. So the Innovation Center, including the WISeR model as one important piece of that, is really designed to address those problems. We have 3 strategic pillars and 1 foundational principle. The 3 strategic pillars are more preventive care. Let's try to nip things in the bud before we get sick or reduce how serious the illness is. We also want to empower consumers. We want to make sure, and when I say consumers, I mean patients. We want to make sure that they have information so that they can make decisions, and in a way that's accessible to them, that's digestible, that's understandable. We all get lots of, I get from my credit card company, all sorts of, it's in 6-point font disclosures that they mailed me in the mail all the time. It's not necessarily, I didn't intend to throw shade at the credit card companies on this podcast.
Yeah, no,
we want to give people information that is actionable so that they can make informed healthcare choices for themselves. And then the third pillar of the Innovation Center is choice and competition. An important component of that I think will be of a lot of interest to your listeners is empowering independent physicians, making sure that there is more competition, bringing more competition to rural areas, bringing more competition really across the United States so that patients can go wherever they want for services. Those 3 pillars are all built on a foundational principle of being very, very careful stewards of the taxpayer funds. So
not only increasing competition, but patient safety has been one of the core pillars of WISeR. So how does WISeR fulfill that particular principle?
So WISeR is, the way that I look at it, I feel like I need to go backwards a little bit. And I hope you'll come with me for the ride.
Yeah.
In June, Secretary Kennedy announced what we call around these halls the Kennedy Pledge. And what he did is he sort of partnered with a whole bunch, dozens of private health insurers to agree to do a better job with prior authorization, to make sure that decisions were being made faster, more accurate, and in a more transparent way. And what I see WISeR as is this opportunity to role model how to do prior authorization right. Our plan is to test how to use advanced technology to make timely, accurate, transparent decisions in a consistent way and share all of that information with everyone so that we can hopefully get to a place where we're even doing like auto approvals. Your question is, how do we select the services? Because we did select a small number of services to start with. There are over 14,000 codes in Medicare Part B. We picked only about 100 for WISeR. Very, very small. And I know that WISeR's gotten a lot of attention, and I'm glad that it has, because I think the opportunities here are huge, but it's a very, very small percentage. And in picking those codes, we looked at a few very key factors. One is we wanted to make sure that the payment and coverage policy was clear. So for all of the WISeR codes that we picked, there are national coverage determinations or local coverage determinations that are publicly available that say exactly when Medicare is going to pay or is not going to pay for certain services. So we wanted to make sure that this wasn't a gray area. There are very clear, clear principles. Cause pain, cause all these other complications we were talking about before, risk of hospital-acquired infections, unnecessary introduction of anesthesia, things like that. We wanted to look at things where we felt like there was a real risk of patient harm. We also wanted to make sure that these were non-emergency services. And they're generally outpatient. We're not looking at inpatient services. We're not looking at, like we're wheeling Amy Turner into the emergency room. Should she get this or should she get that? These are usually things that are scheduled in advance on an outpatient basis. And then we also looked at fraud, waste, and abuse. We spent a lot of time looking at anomalous billing from information that we have at the Center for Program Integrity. Here at CMS, we looked at OIG reports, which is HHS Office of Inspector General. They do civil and criminal investigations. They put out a lot of reports on where there have been areas of abuse. We talked to DOJ. We looked at independent court cases, and we tried to pick areas where we felt like there is an established sort of record and pattern of there being high fraud, waste, and abuse. That doesn't mean that every doctor is, far from it. To be honest, I think that probably for a lot of these codes where we're going to find denials, it's probably going to be a small bucket of doctors that in some ways are driving a lot of the denials. That's what I expect to find. But we'll see. This is a test. So I'm chatting a lot, but I feel like it's making me think of something else I want to say, which is that you had asked about what's a model. That is an excellent question. So when we are fulfilling our statutory mission of looking for ways to either bring down costs while holding quality constant, improve quality while holding cost constant, or do both, we run a model test. There are comparators. It's kind of like a scientific experiment where we have a hypothesis about what we think is going to happen. We run the model test. WISeR is being run in 6 states. We run it in 6 states, but then we also have comparators to say, if it wasn't for the WISeR model, what are happening in comparable states operating under the same LCDs and NCDs, which are those local coverage determinations and national coverage determinations that are about the same size, that are maybe nearby and experiencing some of those same geographic norms. Different parts of the country are different. So we run a model test so that we can say, well, here was our hypothesis. Is that the way that it turned out? And we can react along the way. I know you probably have more questions, but I'll say one more thing before I take a breath and pause, which is our intent here in WISeR. What we had planned is to do this for up to 6 years, but our intent is to constantly reevaluate along the way. Compared to the initial set of codes that we put out, we already pulled some of them down. We got a lot of feedback from both, for example, the American Hospital Association, American Medical Association, the state AMAs we are talking to where we're doing these, running the WISeR model. And there were some decisions to say, you know what, I think we're actually not going to use certain. And our intent is to look at the first, WISeR started 1/1/2026. Just started about 6 weeks ago. And our plan is to look at the first 6 months of data. And we're not afraid to make changes. Could be we pull more codes, could be that we do certain things differently. Our plan is to be absolutely vigorous in analyzing and performing oversight of how this is going. And if we need to make changes, it's something we're 100% willing to do.
This episode is brought to you by Jane, a practice management software and EMR built to support you in the day-to-day work of running your practice. If you're a health or wellness practitioner, you already know the care you provide starts well before your client arrives and extends far beyond the treatment room. Jane is there to support you in every part of that experience. With online booking, your clients can book at a time that works for them. And with features like notifications, they'll even be able to grab last-minute openings when they pop up. It's an easy way to keep your schedule full while getting your clients the care they need. During your appointment, Jane's AI-powered documentation feature can help you thoughtfully take notes so you can stay present with the person in front of you. And after appointments, you can end your time together on a healing note, not a transactional one, by charging the card on file. To learn more about how Jane can support you and your clients, head to jane.app/demo. And one last thing, if you're ready to get started with Jane, you can use my code in the show notes for a 1-month grace period on your new account. Can you tell us which states you started in?
Sure. Now I have to look it up to make sure that I get it right. Our states are Arizona, Washington State, Oklahoma, Texas, Ohio, and New Jersey.
Oh, wow. Okay. So like regions of the country that you picked. Yeah. Those seem like good states to start with. And could you give us an example of if you can, of a code that you're currently evaluating?
Sure. And we'll see if I pronounce it correctly. I am a lawyer, not a clinician, but we're looking at knee arthroscopy, skin substitutes, certain spinal surgeries and interventions. It is, again, going back to like, it's not if you think you broke your arm. It is not like, do I need an x-ray? We're not talking about like somebody who wants some sort of like cancer treatment or something like that. Skin substitutes is something that has been, in the news a lot lately, a lot of increased costs, lots of questions about what's going on there. CMS has a multi-pronged approach to addressing skin substitutes and trying to figure out, are they appropriate? Are they not appropriate? There are a lot of different things that we're looking at. And that is one area some folks may be familiar with. There was a New York Times article that ran, now I'm going to guess maybe like 18 months ago or something, where there were sort of some investigational reporting that was done to indicate that, maybe sometimes patients that are in hospice are having these very expensive skin substitutes placed on some of their wounds, something that not only is expensive, but if left, there was some language in the New York Times article about like smell of rotting meat, I believe was like the word that was used. Like there's a real risk of patient safety if these aren't being done right. So those are some examples of some of the codes that are part of WISeR.
Right. And prior authorization can be a barrier to executing care in a lot of these ways, right? And so you mentioned using advanced technology to help with this problem. And prior authorization has been an issue for a long time. And I'm glad that it's getting addressed. But how are you using, I assume you're using some kind of AI or machine learning technology to make clinical decisions quickly, but there's also a lot of concerns to that. So how are you integrating advanced technology? And then how are you ensuring ethical, transparent clinical decision-making?
These are excellent questions. So first, I should point out that for providers that are in these states that want to use these services, if that's the right way to put it, with respect to their patients, they have a choice. They can either go through a prepay review, which means the service is provided, and then there's prepay review, which is something that was well established under statute that CMS can use before paying any claims, or they can opt for prior authorization. So every physician can make that choice, and they can make that choice on a service by service basis. It's not like they have to opt in and then they're in for all their patients for a certain period of time. So they can make that choice. Prior authorization is appealing, I think, from a patient safety perspective, because it means before the service is provided, there can be an intervention. And a lot of this, I think, is an opportunity for education to say, let's make sure that providers know exactly what is payable and what is not payable, and what are the, current generally accepted standards of medical practice. Make sure that they're being consistent with that Medicare coverage and payment policy. But so first, I wanted to address providers make a choice. If they do opt for prior authorization, going back to this is a model, this is a test. So we have 6 different WISeR model participants, and they are each using their own technology to make these decisions in an expedited way. The idea is not, hi, I'm the government, I'm here to help you, if I were to use a cliche. The idea is to turn to the private sector and test this, see which model participants use which technology. We're going to evaluate them again for accuracy, for timeliness, for transparency, for consistency, and make sure that they are getting it right. So we are auditing. To your point about AI can be a wonderful thing. It may very well be that AI can do this auto adjudication to get to yes, auto approvals, where a doctor completely understands, and sort of making this up because each of the model participants is handling this differently. But let's say there's a flow chart, and if the doctor says yes for all of these different 10 questions, it will be approved. It may very well be that they can move through the flow chart that way. And my hope would be that then they have the flow chart, they understand the flow chart, they know what is needed. They know if they don't have, let's say, for example, a certain scan within the last 6 months, if their last scan is 8 months ago or something, it's too old, it won't be approved. We can sort of give them all the information to help them comply and make sure that the doctors know what is needed in order to make like the right decision consistent with Medicare payment and coverage policy. So that's one piece of it. They're all going to be using their own technology, and it is embedded into our contracts with those model participants that they do education to the provider community to make sure that they understand, and it's not this black box of how these decisions are being made. But to your point about auditing, it is very, very, very important to us at CMS to do like vigilant oversight. We are doing this in multiple ways. One is your use of the word audit. That is very accurate. We are going to be pulling all sorts of data to look at not just our decisions being appealed. And I should point out, if decisions are being appealed, that is a data point of ours in and of itself, separate from whether or not let's say a model participant does not grant like a prior authorization, the medical provider can still provide the service and they can use the appeals process. Ultimately, that may be upheld. The decision to pay may be upheld on appeal, maybe paid or maybe not paid. But just the fact that there is an appeal is a data point that we're looking at, because if there are a lot of appeals, even if the model participants sort of like non-affirmation is the word that we used of the service is upheld, if too many doctors are appealing, they don't understand the criteria. So it's not meeting our standards for making sure that there is transparency and that providers are not being surprised. They don't know what's going on. We want to make sure that there's no surprises. We want lots of transparency here. We're pulling information in terms of, we're doing providers surveys in terms of their satisfaction, patient satisfaction. We have ways that providers can contact CMS if they want to lodge complaints. We have edit tests in 1-800-Medicare. If patients are calling and they're logging complaints, we're looking at how long it is taking to make decisions. We'll be pulling certain samples and doing accuracy checks to make sure that we agree with the decisions that are being made. I mean, really the best term that I have is like vigilant oversight. Mm-hmm. We recognize how critically important this is. We recognize how scary prior authorization can be, for good reason. Go back to the Kennedy Pledge. We think sometimes it has not been used right in the past. We really want to get this right. And our intent is to perform very, very close oversight to make sure we know what's going on and can provide feedback to our model participants. Yeah. What does feedback mean? It could be that there is a quality adjustment that's built into how we pay them. So it could be payments are withheld or recouped. It could also mean that a model participant is terminated from the WISeR program. We are not afraid to withhold payments. It's built into our contracts with them, and we're not afraid to terminate model participants if we feel like they're not getting it right.
Yeah, wow. Yeah. I know we're running a little tight on time. So I wanted to ask, when you look at success in 2031, I know you're evaluating in June, but what does success look like for patients, providers, and beyond?
Okay, that is an excellent question. I think that what we would do in WISeR is raise the bar for private commercial insurance. That is my background. For what it's worth, we sort of started this conversation by talking about how I had recently come to the Innovation Center. The bulk of my career, I had actually spent at the Labor Department, where I both wrote regulations and oversaw enforcement of private sector employment-based insurance. This is an opportunity to show how, repeating myself here, show how to do prior authorization right. Mm-hmm. And success would be if other MA plans, if other private sector commercial insurers, whether they be in the marketplace, whether they be employer-sponsored insurance, whether they be self-funded employer plans, started looking at what we're doing and what the information that we are sharing in this transparent way and said, hey, I want to do that. That would be success. It would also be success, I would be remiss if I didn't mention, is if we improved safety, if there were fewer unnecessary yet risky procedures being performed where our quality went up. I would love it if, being in the hospital, you're exposed to all sorts of things. If there are patients that would be better off doing therapy first and got good results from therapy and avoided some sort of very invasive surgery, that would also be a great result, in my view.
Yeah, that's a great review. And just as a final question for you, where do we follow along? Where do we look for updates?
We have a website. I will have to send it to you because I
Great.
don't know it off the top of my head.
Yeah.
But we do have a website. It is where we explain the states. We explain what the codes are. We explain what to do if someone has a complaint. It's where we'll put the evaluation material. There's all sorts of information on the website.
Amazing. Amazing. Well, Amy, thank you so much for being a guest on the podcast. Thanks for being here. And we look forward to following along, and we'll check in June and see where things are at. But yeah, thank you again so much. We really appreciate it.
Sure. Looking forward to it. Thanks, Jeremy.
If you enjoyed today's episode of The Claim Game, please take a moment to leave us a rating and review wherever you listen to your podcasts. It really helps new listeners to find us. Make sure you never miss an episode by subscribing to The Claim Game on your favorite podcast app. Your feedback means so much to us. We want to provide valuable education about revenue cycle management. So if there's something we didn't cover in our topic that was a burning question for you, please let us know so we can try to get you the information you desire. You can find the links to all resources we mentioned in this episode in the show notes. And if you want to dive deeper into our resources, we have two places you can do that. First, you can go to our blog at practicesol.com/blog, where we have 8 years of educational blogs. If you want to learn more about what Practice Solutions does, reach out. We'd love to hear from you. Just go to practicesol.com to learn more and to connect with one of our awesome people on our team. Thanks for listening. We are Jeremy and Catherine Zug, and this is The Claim Game. See you at the game table next time.